This is going to be a quick rundown of diseases of the endocrine system, which is chapter 17 in our text. Here you can find the learning objectives, and my suggestion is after you go through the chapter, reading it, and this lecture, you can go through each of these bullet points and see if you can accomplish each of those objectives. So first we need to take a look at the anatomy of the endocrine system. So what you see here is all of the organs and tissues that are working within the endocrine system. Those that are shaded in purple, like the pituitary gland, the thyroid gland, the parathyroid gland, and the adrenal glands, those are solely working in the endocrine system. However, you'll see all of these green. Those are showing other organs that work as accessory organs to the endocrine system. So what you can see is that all of the organs contributing to the endocrine system are scattered throughout the body. And that's important because each of these are going to help produce hormones, which is the job of the endocrine system. And those hormones might be secreted from multiple different endocrine glands, or individual endocrine glands might have a specific hormone that they are in charge of. So hormones are released, and they are what can manipulate metabolism in a lot of ways, but also send signals to other hormones and cause body systems to work differently. So here you see that major hormones, most often are going to function with reproduction, growth and development, maintaining homeostasis within the body, and then regulating metabolism and nutrient supply. So if you think about insulin and glucagon, which we've talked a ton about in your junior year classes, but also cortisol and epinephrine in their role in modulating energy metabolism through the different macronutrients. So you can see here that there are a variety of different hormones involved in the body, and you can also see where they sort of are coming from. But each hormone can be classified as a peptide or protein, an amine, or a steroid. And based on those classifications, they will have different functions. So in physiology of the endocrine system, we are looking at what is actually happening with those hormones and the jobs or what those hormones can do. Just like anything else in any other body system in the human body, we can have things working under threshold or over threshold, and that can be a hypofunction of an organ or hormone, or it can be a hyperfunction. So if we see hyperfunction, we're typically talking about a higher concentration of a hormone in the body, whereas hypofunction means that there are insufficient amounts of hormones in the blood. So you've probably been familiar with these terms as they relate to the thyroid hormone. We've heard of hyperthyroidism and hypothyroidism. We will talk more about this, but basically hyperthyroidism means that we have more thyroid hormone in the blood than necessary, whereas hypothyroidism means we have not enough thyroid hormone in the blood. Similarly, we can also see inadequate responsiveness from target cells as they relate to hormones. Now, this would be similar to like our insulin receptors not accepting insulin appropriately. That would be abnormal target cell responsiveness. Now, the major organs of the endocrine system include the pituitary gland, and this is found at the base of the brain, and we divide it in between the anterior and posterior pituitary. These we talked a lot about in nutrition through the life cycle because these often relate to the hormones related to growth and development. So, for example, from the anterior pituitary, we see growth hormone, prolactin, ACTH, TSH, which is the precursor towards our thyroid hormones, FSH, which is our follicle stimulating hormone, and luteinizing hormone. So those should sound really familiar to growth and development, also the reproductive cycle. On the other hand, our posterior pituitary gland secretes vasopressin and oxytocin. We talked about oxytocin in Diet 305 Nutrition Through the Life Cycle as well, because this was heavily implicated with breastfeeding and lactation. Next is the thyroid gland. This is the gland that's located in the neck, and it's always referred to as a butterfly-shaped organ. And the thyroid gland is predominantly responsible for controlling our metabolic rate. I always like to tell students, think of the thyroid gland as our thermostat. And our thermostat is what controls the rate of metabolism or the rate of heat production in the body. So the thyroid gland is responsible for secreting thyroid hormone. And we have two forms of thyroid hormone. We have T3 and T4. Our more active thyroid hormone is T3, but T4 is what is predominantly produced, and we have to convert to T3. Now, in order to get thyroid hormone, we have to have some signaling going on. So we signal through the production of TRH, thyrotropin releasing hormone, stimulates thyroid stimulating hormone or TSH, and that tells the thyroid gland how much thyroid hormone should be produced. So T3 and T4 are our thyroid hormones, and what they do is when they are secreted properly, they increase metabolism, which impacts growth and development and increases the secretion of catecholamines. So if we had too little thyroid hormone production, that would be called hypothyroidism, and we could see decreased metabolism, impaired growth and development. Next is our adrenal gland. The adrenal gland sits above the kidneys on either side, so very connected to the kidneys. We have our adrenal medulla, which is the innermost portion of the adrenal gland, and the adrenal cortex, which is the outer layer. So the adrenal medulla plays a role in the sympathetic nervous system, and so that's why you see this relationship with epinephrine, norepinephrine, and our catecholamines, including cortisol. Then we have the adrenal cortex. Oh, sorry, I meant to say this is over here. Adrenal cortical hormones is going to be cortisol. So that's going to be secreted from the adrenal cortex. Then we have the pancreas. The pancreas we talked a lot about previously because it helps to regulate blood sugar. The pancreas secretes insulin, which helps to usher glucose into the cells, therefore lowering blood sugar. And it also secretes glucagon, which helps to increase the liberation of glucose from glycogen in the liver. So the exocrine pancreas is responsible for secreting digestive enzymes, whereas the endocrine pancreas is responsible for secreting these hormones that we're relating to metabolism. So the pancreas is highly involved in the digestion and absorption of proteins, fats, and carbohydrates, particularly when we're in the fed state. And they are the pancreas and the hormones that are secreted from the pancreas are absolutely necessary for normal digestion, absorption, and metabolism. Insulin is the major hormone that's produced by the pancreas. We need to remember that insulin is an anabolic hormone, so it helps to store. It tells glucose to go into the cells, and when we have a surplus of glucose, we can then store it as glycogen or fat. How exactly insulin is working? Insulin is caught by the insulin receptors after it is secreted by the pancreas. Whenever the insulin receptor catches onto insulin, it says to GLUT4, which hangs out inside of the insulin-dependent cell. It tells whenever insulin is accepted to that insulin receptor, it tells GLUT4 to move towards the membrane. And when it does that, it opens up the membrane and allows glucose to flood through. Now, if we have insulin resistance and insulin is unable to be caught by this insulin receptor because it's faulty, then it doesn't send the signal to GLUT4 to be translocated towards the cell membrane, and we can't bring glucose into the cell. That essentially is what insulin resistance is. We've talked about the glucose transport proteins. So I pulled this from our diet for 11 information. You can go back and revisit this if you need a brush up. So the opposite of insulin is glucagon, also secreted by the pancreas, but its job is to release stored glucose because there's not enough circulating in the blood or the tissues. So whenever you see glucagon, you can think glucose is gone. What do we need to do about it? So what happens is when glucagon is released, we stimulate the breakdown of glycogenolysis. We upregulate gluconeogenesis, and we break down fat to release energy. Now, I've alluded to some challenges in the endocrine system whenever insulin isn't working properly, or if we're not producing adequate amounts of insulin. So this is all alluding to diabetes mellitus. Now, there's 3 major forms of diabetes. We can have a defect in the insulin production, meaning that we are not producing any insulin, and that would be type 1 diabetes. This is an autoimmune condition. So at some point, a virus attacked the pancreas in the area that insulin is secreted. And now insulin is no longer secreted, and we have type 1 diabetes. With type 2 diabetes, this is a condition that is related to defective insulin receptors, or the shape of the insulin isn't appropriate to be caught by the insulin receptors. So basically, it's insulin resistance. The insulin's not working properly. That's type 2 diabetes. Now, the version of type 2 diabetes or insulin resistance seen in pregnancy is called gestational diabetes. Typically, people who are diagnosed with gestational diabetes have some underlying insulin resistance prior to pregnancy. That's what the latest research is showing us. And therefore, after pregnancy, they have a greater risk of developing type 2 diabetes. Now, what you need to know about diabetes is that because of the systematic impact of high blood glucose or hyperglycemia, we can see long-term damage to a variety of organs. And if you think about it, it's any of those organs that are going to have that microvasculature. So our eyes, our kidneys, the nerves, the heart, and blood vessels. All of those can be damaged when we have too viscous of blood because it's too sugary. Think about honey. Honey is very thick. The more sugar that is in the blood consistently, the thicker the blood is, and that can cause damage to the vessels. So here's some more information about type 1 diabetes. Basically, this is hyperglycemia caused by inadequate production of insulin. The side effects that we see are the 3 Ps: polydipsia, polyuria, and polyphagia. So we're peeing too much, we're very thirsty, and we're very hungry. And a lot of that has to do with where we need to pee to correct the very sugary blood in urine. We want to dilute that very sugary blood, and so we want to drink more water. And because we can't get glucose into the cells, our cells are actually starving for energy, starving for glucose. And so we want to eat more in turn. So what can happen if somebody has type 1 diabetes and is undiagnosed? We oftentimes will see them lose a significant amount of weight prior to their diagnosis. And that is because despite having hyperglycemia chronically, because the insulin can't get the sugar into the cells, the person is in this metabolically starved state. And so if they can't utilize glucose, their body has to switch to, or their cells have to switch to using fat. Now, what can then happen is this can escalate even further, and they will start to produce ketones. Now, this is a very common occurrence in a young adolescent who is diagnosed with type 1 diabetes. They may have an illness, they start to drastically lose weight, and then we go and check their A1C, and believe it or not, they have type 1 diabetes. Now, this can also happen in other people with type 1 diabetes, maybe if they forget to take their insulin. If this happens, the same problem can occur where their body will start to break down fats, push them into ketoacidosis, And if we have severe ketoacidosis, that person can be diagnosed with something called DKA or diabetic ketoacidosis. This leads to major disruptions in our electrolytes, hypovolemia. It can cause issues with the renal function. It can cause fluid and electrolyte imbalances, acid-base balances, and ultimately these Kussmaul respirations, meaning that people can have a hard time breathing. Individuals who fall into DKA also can come into some sort of coma. And so it's very important that they are treated to bring their blood sugar down. And also, as dietitians, we can help make sure that we understand why they weren't taking insulin. Did they not have access to it? Did they run out? Did they forget? Those kinds of questions are important for us to ask. All right, so looking at type 2 diabetes, again, this is an insulin resistance. This can be caused by a variety of factors. We understand that it's multifactorial, but essentially the body isn't producing adequate amounts of insulin and or the insulin is faulty. So the insulin receptors aren't able to catch on to the insulin, make GLUT4 move, and allow glucose to move into the cells. Now, we can identify this insulin resistance sort of incoming prior to somebody is completely diagnosed with diabetes, type 2 diabetes. Ideally, people are getting blood sugar regularly to identify something like prediabetes. So prediabetes is if we have an A1C of 5.7 to 6.4 or a fasting blood sugar of 100 to 125. So we've not gone to full-blown diabetes with a 6.5 A1C or higher or a fasting blood sugar of 126. So these people are going to be at higher risk for developing diabetes. And we really, really want to intervene early and help them to adopt lifestyle changes to prevent them from progressing towards type 2 diabetes. Now, I mentioned the A1C. That stands for the glycated hemoglobin assays. This is a measure of average blood glucose about 3 months time span. So it can give us a good idea of the average blood sugar that an individual is kind of hanging out at. These are typically used to diagnose, but we can also use a glucose tolerance test. We can take a look at the presence of antibodies if we suspect somebody has type 1 diabetes. So there's a variety of ways that we can diagnose the different versions of diabetes. In general, though, people who have type 1 diabetes are going to be required to use exogenous insulin, and that would be insulin injections. But we also want to provide nutrition therapy and encourage physical activity to help them maintain their blood sugar. Other individuals who have type 2 diabetes, they may or may not need insulin depending on the status of their condition. But a variety of medications can be used in conjunction with nutrition therapy and lifestyle changes to help support the person's blood glucose homeostasis. Now, we can provide insulin in a variety of different ways. There are continuous or there are pumps that people can use, insulin pumps. We can use syringes. And then most people will use insulin pens. And those are set to provide the specific amount of insulin that the individual needs. There's also a variety of insulin types, and those types are based on the onset of action, the peak time, and the duration of action. So it's our job as dietitians to help people understand the role of their insulin in their eating pattern, when to take it, and also how to help them understand how to dose it for themselves. These are a list of medications that are used to help achieve glycemic control along with nutrition therapy and physical activity. And we've also talked about surgical procedures that can be used to encourage weight loss to improve insulin resistance. But also they're doing pancreatic and islet cell transplants that are an option for people with type 1 diabetes whose insulin cells are not working to produce insulin. So we will talk about the nutrition therapy recommendations for diabetes in class and do some case studies on those. But in general, we want to encourage patients to come and receive MNT from a dietitian. Most insurance companies will provide reimbursement for this. This is important for you to learn the recommendations for glycemic control, what is normal and what is above normal. And then what I mentioned earlier is if we see somebody with an A1C of 6, we can understand that their mean blood sugar is usually hanging out around 126. If somebody comes in with an A1C of 10, we know that their mean blood sugar is typically about 240, which is very high. Physical activity can play an important role in improving glycemic control for people, other than these additional benefits that I've listed here. But we also need to understand that whenever we do encourage activity, we can also see hypoglycemic and hyperglycemic events. And so we have to help our patients and clients understand timing for eating, exercise, and insulin regimens to make sure that they're not having those hyperglycemic or hypoglycemic episodes. These are some common complications that we see with diabetes. One is the dawn phenomenon. What we see with this is that the hormones that control the circadian rhythm can actually cause hyperglycemia in the earlier morning hours. So we can, if patients are noticing this, we can help to adapt their eating pattern to mitigate this in their whole regimen. I already talked about DKA, but other than that, what we really need to understand is that short-term illnesses can affect a person's regimen, and it can affect their blood sugar as a whole. And so we have to help them understand those things. Now, gestational diabetes is the insulin resistance that we see particularly during pregnancy. So we'll see the same signs and symptoms. But the reason that we want to identify gestational diabetes during pregnancy is because we can see more complications with birth and with infants who are born to moms with hyperglycemia. Um, so the reason that, or the way that we identify it is through glucose tolerance test. So pregnant mothers will consume one of these drinks that is either a 100-gram glucose load or a 75-gram glucose load, and then they'll have their blood sugar checked an hour later. If they don't have positive results with the 1 hour test, then they'll do a higher load like the 100 and have their blood sugar checked 1 hour, 2 hour, and 3 hours later, which I can share my experience with that. So really we want to optimize blood sugar during pregnancy because of those complications that can occur with hyperglycemia. So we can provide nutrition counseling. Sometimes we will, or mostly we will typically provide insulin therapy. Some oral medications can be used, but in general, insulin is the primary medical treatment. So hypoglycemia is what we call a low blood sugar. We can have fasting hypoglycemia just because we haven't eaten enough and we have excess insulin hanging out. Or we can have somebody who has diabetes and administer too much medication or insulin to lower their blood sugar, and now they have reactive hypoglycemia. So we can help people understand what it feels like to be hypoglycemic and help them to, or like what those symptoms are. So blurred vision, headache, slurred speech, and weakness, those are all signs of hypoglycemia. If somebody has, or someone consistently has fasting or reactive hypoglycemia, we can encourage smaller, more frequent meals with complex carbohydrates, fiber, and protein to help regulate blood sugar.